A little bit different. This is a fireside chat. And Karen Malski and I will talk about really the power of patient advocacy in advancing precision medicine. We heard a lot today about folks wanting to do certain types of genetic testing and having access to resources. But what happens when something is very clinically meaningful, but oncologists don't want to do it? How do you move the needle? Karen is a public health official, but she's here today as a member of the Advocates for Universal DPYD testing. Is it audit? Do you say audit?
Correct.
And as most of you already know, DPYD testing is a pharmacogenetics test, and it identifies individuals who can't break down certain chemotherapies that are widely used, 5-FU and capecitabine. And because patients with these pharmacogenetic variants can't break down these chemotherapies, they are at risk for severe, and in the case of Karen's husband, fatal toxicities. I had the privilege of reporting on Karen and her husband Larry's experience at Mass General Brigham, where actually DPYD testing policies have changed because of Karen's advocacy. So could you, as a starting point, take us through what you and your husband experienced at Mass General?
Absolutely. And before I do that, I just want to define two acronyms that you're going to hear us talk about. And one is MGB, which is the system in Massachusetts, Mass General Brigham. And the other is MGH, which is Massachusetts General Hospital, which is part of that system. And MGH is where my husband got his care. So just in case you hear that noted, I just wanted you to appreciate that. So Larry and I lived on Cape Cod, which is a peninsula off the southeastern coast of Massachusetts. It's about 2 hours outside of the city of Boston, so it's quite a trip to get up into the city. We raised our 3 children there, and we really lived a just very happy and beautiful life. Larry was an extraordinary husband and father. He taught our kids to be curious, kind, and for each other to celebrate their wins. He was there for me and for us every day. In the fall of 2022, Larry began experiencing chronic anemia, and we just couldn't figure out what the source was. Eventually, we discovered that he had a colorectal cancer, and that cancer was removed at MGH in January of 2023. He was then referred to MGH Oncology, and we spent 3 months considering treatment options, much of which was focused on side effects. That was such a concern to him. There was ample opportunity in that 3 months for oncology to talk about toxicities. Informed consent requires that all risks be discussed, even if they're considered rare. We weren't given that information, and it's a regret that I live with every day, because ultimately Larry did decide to start chemotherapy. He did that in hopes that he'd prevent a reoccurrence. And it's, in his words, he did it because he didn't want to leave me a widow. And that's specifically what he said. On April 24th, Larry's chemo began. 4 days into treatment, he started complaining to me about mouth sores that progressively worsened. He was seen several days later in the ambulatory clinic where DPYD testing was conducted. Larry was admitted to MGH the next day. He was in extraordinary pain, could not speak, he could not swallow. The triage nurse in the ED asked him about his pain level, and this is seared in my brain. What he did was this. So he was admitted. 4 days later, he was transferred into the intensive care unit and intubated, and he remained there until he died.
So this what you described as a catastrophic event in your life, and this is such, you must have been going through so much chaos and stress, and in the aftermath of it all, after his death, when you're taking stock of what went wrong, which I'm sure you did, Larry got so many different types of treatments and tests in those last days to try to manage everything that he was going through. How did you learn about DPYD testing? And how did you figure out Larry should have been tested earlier?
Absolutely. So as I mentioned, Larry was first tested in the ambulatory clinic the day before that he was admitted. That was the first day that DPYD or DPD deficiency was described. One of the things I don't even think you know is Larry was hard of hearing because in the very bad winter of 2015, he was out with our snowblower and he had some hearing deficit because of that. So I was there with him for every patient encounter that we had, helping to support him and ensuring that he could hear and understand what was going on. After his admission to the unit and before his ICU stay, and I did request all of the records after his visit, there is a note from the attending physician in his record with a suspicion of DPD deficiency. Again, nothing was said to us at that point. A day after being admitted into the ICU, Larry's testing returned, and it indicated a complete deficiency. I began to understand that what he was experiencing was a 100-fold overdose to his chemotherapy. It was like whack-a-mole for about 3 weeks, and I could describe for you all of the horrific symptoms that he was experiencing, but I could just encapsulate it by saying he was burning from the inside. At that point in the ICU, I began to understand that Larry's cascading effects and his decline was a result of his undetected DPD deficiency. My research at his bedside was terrifying. And when I asked how and why this could happen, I wasn't told that they missed the black box warning, which at that time had said it should be discussed with us. I was just told that it wasn't the standard of care in the United States.
So how did you Google, I'm paraphrasing, but you Googled and learned about DPD deficiency that way at your husband's deathbed. But then how did you find audit? How did you find the advocacy group?
Yeah, so for the next year, it was really a time of grief and sadness and trying to figure out the path forward in this new normal that was my life. It was 17 months later as I was getting ready to walk my daughter down the aisle and my son was to support her through what should have been her father-daughter dance that I started my research. Larry should have been there, and I was getting angrier and angrier about this, and I wanted to do something. So as you said, through the wonders of Google, I discovered the advocates for DPD, DPYD testing. They're a group of medical professionals and patient advocates who are working to change the standard of care for patients receiving these chemotherapies.
Some have argued, for example, that DPD deficiency is really rare. So, and there's an anecdote. So, once patients start declining, you can give the anecdote, and testing may not be necessary. But given how quickly patients with DPD deficiency decline, and if DPYD testing isn't in the forefront of everyone's mind because they think it's too rare or they don't know about it, is VistaGuard, which is the antidote, is that a reasonable option in your opinion? Larry did receive it, but not in time, right?
That's correct. So first of all, at a high level, I don't understand why we would allow anyone to experience a toxicity when there's a test. At the end of the day, this is a drug interaction and it's a patient safety issue. I also want to just spend a very brief moment addressing the description of this as rare. I really think that this is underreported. When I look at Larry's death certificate, his cause of death is listed as sepsis, pneumonia, and mucositis. He died from DPD deficiency, and it just leads me to wonder how many other patients are being injured and dying because of this. And then finally on VistaGuard, Larry did receive VistaGuard. VistaGuard is supposed to be administered 96 hours after stopping cancer treatment. Larry's test did not result back within that 96 hours. He ended up having VistaGuard administered 240 hours after ending his cancer treatment. And the ironic thing about VistaGuard is it's an oral medication. At the point that it was being administered to Larry, he was intubated, he was sedated, it had to go through his NG tube, and it seized up and clogged the tube.
So you decided to take your concerns to Mass General Brigham. And specifically, you took it to the folks in charge of safety concerns. And you wrote a letter. How did you kind of, at this point, how are you formulating your strategy, and how did audit play a role in that?
Absolutely. So we got through the wedding, which was wonderful. And I found a woman named Lindsay Murray. And I found her through a KFF Health News article in 2023. The article told the story of her mother, Carol Rosen, who was a 70-year-old woman being treated at the Dana-Farber Cancer Institute, right down the block from MGB or MGH. And she to Dana-Farber, asking them and urging them to implement a testing program. And she heard back from them that very same day, and soon after, a testing program was implemented. Lindsay became my role model and really how I thought to approach MGB about this issue.
So I was hoping that you would maybe read a little bit from the letter that you wrote to MGB, just so we have a sense of how you approached and framed the issue.
So as residents of Cape Cod, we made the decision to travel to an academic medical center seeking the very best for Larry's cancer care. It is not lost on me that if we had chosen Dana-Farber rather than Mass General Cancer Center, he would have been screened for his complete DPD deficiency and his death would have been prevented. And I hope you can imagine my shock when I learned that following Larry's death, no protocol changes were made at MGB to improve clinical outcomes for patients receiving 5-FU or capecitabine.
And I always thought that this letter was incredibly remarkable. This was also the point at which I was writing the article, and I wanted to wait to publish my article because I wanted to see how this interaction went. And when I saw this article, I thought, wow, she's making a safety issue, but it's also a business case, right? Healthcare systems tout their ability to provide precision medicine all the time. So what happened next? How do they react to this letter?
Yeah, absolutely. So my approach was to go through quality and pharmacy rather than the cancer center, because again, and as I've said, at its core, I believe that this is a drug and a patient safety issue. I was pleased that the chief quality officer was receptive, and I joined a virtual meeting with her and with pharmacy to talk about this and really be very explicit about the fact that I was looking for them to make a commitment to testing. I didn't get there on the first meeting, but I was invited to a second meeting in early January, and that was an in-person meeting, and it was going to be, again, with quality, pharmacy, and this time oncology. And to my delight, when I walked in the room, the oncology representative was my husband's oncologist, Dr. Jeffrey Clark, and he was there to share the news with me that the system had decided to implement a program, that he had actually fast-tracked it and had it underway. And it was going to not only be at MGH, but across all of their health system hospitals.
Do you think this change in policy to do pre-treatment DPYD testing would have happened, or do you think it happened because Dr. Clark pushed for it? Do you need a champion like him to make change like this?
Well, I do think you need a champion. I wasn't the first devastated family member to urge Mass General Brigham to institute a program, but every other family member had gone through oncology. And I don't know what the issue was with oncology leadership, but they were not open to discussing this. So I really think that going through quality, going through pharmacy is the way to go in making these changes.
So let's talk a little bit about what's happened since. I mean, the article about your and Larry's experience came out in January of this year, the same day that the FDA and AACR hosted their public meeting on DPYD testing to gather public input. After that, the FDA opened a public docket to solicit further information and gather evidence on what it takes to implement DPYD testing and if it's actually improving outcomes. And then over the last month, that's really when some real change has happened. The FDA updated its label. I mean, as you said initially, the label for Xeloda and 5-FU said discuss this, but there was no pre-treatment testing recommendation. FDA just updated the label to say test for DPYD unless immediate treatment is necessary. NCCN subsequently then updated the colon cancer guidelines to acknowledge the FDA label update. This is essentially what AUD, I mean, even before Larry, audit, from what I understand, have been trying to do these two things with the FDA and NCCN for over a decade. Can you discuss a little bit the hesitancy that you've encountered in your advocacy for why oncologists and cancer centers don't want to or think it's not possible to do universal DPYD testing? And do you think that these changes at the FDA with the FDA label and NCCN, do you think it'll really move the needle in getting more cancer centers to do it?
Absolutely. So I'll start by saying I couldn't be more thrilled by all the progress that we've seen since early October on this front. It's really remarkable. And I said to Howard earlier today, I feel a little bit like an imposter because I do have fellow advocates who have been doing this, as you say, for more than 10 years. And I'm relatively new to the space and I work in state government. Nothing moves fast. So it's remarkable to see how fast that this has moved. And certainly not because of, directly related to my involvement. But to your question on hesitancy, I really think that this is multi-factor. Despite what I've said, this is still thought to be rare. And I do hope that we move the mark a little bit in terms of that reporting. So I think that's one barrier. Certainly the prior FDA and NCCN stances were a big barrier to moving the mark on this. There were insurance coverage issues. There were, and there continue to be insurance coverage issues. I'm working within my home state in Massachusetts on a biomarker bill now to try and get it covered there. So that continues to be someplace where we need to do work, and frankly, change is hard. We have many people who are set in their ways. Their electronic health record might not be set up to support this, so it's difficult work to do. But I will say one of the reasons I think I saw Dr. Clark there that day is if you watch a patient die of this kind of toxicity, I really believe it stays with you and the change just has to happen. So, to your question, do I think because of the FDA and NCC actions that hospitals and health systems are going to change? Absolutely. And I'm thrilled.
So what more needs to happen? I mean, the FDA label says test, but there might be, do you think they could do more? NCCN, only the colon cancer guidelines are updated. So what more do you think needs to happen?
Absolutely. So I think, first of all, I look forward to the FDA updating the label for 5-FU. That hasn't been done yet, and that has to happen. And then to your point, NCCN must expand its guidelines beyond just colon cancer.
Because these are chemotherapies that are used beyond colon cancer.
Absolutely. We want lab companies to continue to offer comprehensive assays and to really look at how they can turn around their resulting. Larry's results took a week for us to receive. And then finally, to our earlier point, I just implore the insurance industry to really take a look at what the costs of these injuries and deaths are. My husband was in the ICU for 3 weeks. A test is $250. We need to do the.
Do you have any closing remarks?
So I just want to share, Turner had mentioned the work that we've done together. She has been by my side since the very beginning in this journey, and her reporting on it has been compassionate, scientific, and just human. So I wanted to thank you for that. She's always been one email or text away, and she had to rewrite an entire article when Mass General.
Yes, initially the article was written. I guess we both, from what you had told me, I had expected that they'd say, okay, thank you for coming to us. And so I had written the article that way, but then you came back and said, oh, they're implementing a program. So I had to rewrite in 2 hours or something like that. But thank you so much for bringing your story. It's really my privilege. So we have about 10 minutes, questions for Karen.
Hi, thank you so much for sharing your story with all of us. I have kind of a two-pronged question. First, in the institutions that you've known to, really implement this type of testing, do any of them do it in-house, or is it kind of going to be one of those send-out labs?
I can only speak right now to Mass General Brigham, and they do send out their testing, but I do believe more hospitals and systems are bringing online the testing in-house.
And that's very similar to what we have seen whenever we actually do the testing. But the second half of that is that we're already sending out. Are you guys advocating for any more extensive pharmacogenomic panels, things that encompass other cytochrome issues with colorectal, specifically like UGTA1A1?
So this public health professional doesn't even know what that is.
Sorry, pharmacist.
Absolutely, no, that's fine. I would say our advocacy group is specific to DPYD testing because it's something that's impacted our family, our loved ones, and our friends.
Hi, excuse me, Jim Palmer from Target Cancer Foundation. As a fellow advocate, I just wanted to commend you on this amazing work. It's really remarkable. Although I'm very sorry that you had to do it. I'm curious about so many things here, but I think my top question is around your process for changing NCCN guidelines. Basically, is your plan now to go apply panel by panel where these drugs are used, or has NCCN offered any opportunity to do this somewhat more holistically rather than having to go through that repetitive process?
Sure, that's a great question. I would say overall, AUT has not had a lot of success as a group collaborating with NCCN, though, as I mentioned, we have a number of medical experts who are part of our organization, and they often have the opportunity to collaborate with NCCN, and we've seen some movement.
Any other questions? Oh, over there.
I just want to say thank you for sharing your story and your graciousness and all of your insight. I really appreciated when you said you were talking to the pharmacist, and it's not something that I've really thought about. We do have a pharmacogenomic panel, and our genomics program would like it to be developed or implemented at the primary care provider level. So we have this pharmacogenomics panel, and it's not being widely adopted by our PCPs because they feel like, well, if the patient doesn't need the drug, why do I need to know? And so we've really struggled with getting it to anchor into patient care. And I'm just wondering about your thoughts around, who kind of owns something like differences in drug metabolism that could impact patients over the course of their lifetime. Whether you feel it's something to really look at the pharmacist's perspective based on what drug the patient might be getting, or if it could be something that's better implemented at a primary care level.
Sure. So I know in the case of NGB, and I'm so glad that I approached it through quality and pharmacy. Their implementation of the program was through their centralized pharmacy. So the pharmacy doesn't release the chemotherapy until they see the flag is signaled in the EHR. I'm not sure if that answers.
I think
that's what I understand about it.
Thank you for sharing the story. And I think you've, through the unfortunate circumstances, really had an impact really across the country. But I'm wondering, if this could be a roadmap beyond DYPD testing. In other words, in your husband's circumstance, for lack of DYPD testing, he had a terrible toxicity. But for lack of NGS testing, people miss opportunities for therapies, some of which could actually be curative. And so I think there's a big picture here, and I don't know if you want to comment on that.
Sure. That makes me think about when I had the opportunity to testify at the Massachusetts State House on the biomarker bill. Everyone who was there and testifying on the bill was testifying on how biomarker testing would enhance treatment for the patients. And I was the only one who was there talking about how biomarker testing would help to prevent bad outcomes for the patients. So, I really think that it's a hand-in-hand situation.
I'm really sorry to hear the experience that you've gone through, but it's inspiring to see what you've done with that experience and how you can help others. I think some of the the comments earlier. There are definitely pharmacy organizations that are focused on these types of issues. Just speak to there's HOPA, there's NCODA that are really focusing on identifying the right treatments for patients and the right ways to apply it, and doing the due diligence of making sure that the testing is done. There's actually like processes that they endorse and they, really put out to anyone in the US, especially and externally as well, to use. So that are, I think that might be an approach to get to the NCCNs.
Absolutely amazing.
Group ahead, I thought I'd take it next. So one of the things I did a quick little search for you. We're talking again, like group, I'm very sorry for your loss and that this led you on a new journey. You'll be able to help other patients. Coordinate a lot with laboratories, and a quick search turned up that Tempus actually offers it in conjunction with their LDT panel. Maybe you and your colleagues could start investing with the laboratories to see about offering it. So right now it's like a one-off that someone would have to order separately and to know. But could the laboratories, through concentrated efforts, who are already doing NGS testing on these patients, just like they offer a PDL1 like it's like water, why wouldn't they offer this as part of the panel? And since it's already recommended, all the other things that come along with it, they offer patient assistance, so the cost shouldn't be a barrier. I would suggest going to the laboratories, and if you wanted any assistance with that, I'd be happy to help you.
Thank you.
Okay, we will wrap that up. Thank you so much, Karen, for your time, for sharing your story, and for your advocacy.